Okay, it's me, Samagya Bhattrai, optometrist by profession. Today I'm here with you as a host for the iTalks program by Mero Eye Foundation, and I feel so privileged to welcome you all for this session. Before starting our webinar, I want to request all the attendees to mute their microphones through audio option that is visible on your screen. And let me also inform you all that we'll be conducting discussion sessions at the end of the webinar. We have already enabled our chat section, which you can easily see on your screen. If you have any questions in between, then you can just drop them there. Our topic for today's webinar is scleral lens and new technologies. And as a speaking delegate, we have Mr. Dr. Thomas P. Arnold. He has completed his doctorate in optometry and fellowship in scleral lens education, and is currently associated with Memorial Eye Center, Sugar Land, Texas, USA. Hello, sir. Are you there?
Yes, pleasure. Thank you for having me.
Okay, thank you, sir. Now I'd like to hand over this session to you. It's our immense pleasure to hear from you, sir.
Thank you, and it's great to be here. I wish everybody the best, and hope you get some benefit from our short time today together. So let's talk about this. So scleral lenses, okay? A lot of us, including myself, just learned about them a few years ago, so we think they're new, but are they really new, or are they something old?
This girl is wearing glasses. Don't believe it? Well, it's true, but here's how it's done. To make contact lenses, the eye is anesthetized. Then Sydney optician Henry Thomas, Australia's only contact lens maker, inserts an impression cup containing a material for taking a cast of the entire eyeball. The mold sets in 2 minutes and then it's removed. A perfect impression. Contact lenses are a boon to actors, are worn by several film stars, jockeys, and athletes. Yes, even glasses are made to measure today. Now the cast is put into a press, and the plastic lens itself is molded. The lens is shaped to fit its wearer's eye, and also to give the same visual correction or aid that would be given by normal glasses. Now the lens is cut to shape from the plastic square, and it's ready for grinding. The plastic is unbreakable, and 2 lenses cost 45 guineas. In America, where the new look is popular, lenses cost 75 pounds. The inside surface of each lens is ground first, a delicate operation demanding a fine degree of precision. Instruments measure accuracy, determining if the lens fulfills its optometric prescription. Then the tiny eyeglass receives a final buffing. There's still a spectacle case to leave lying about, but of course it's smaller, just to make it harder to find. Lenses are fitted, minor adjustments are made, then a buffer solution is placed on the eyeballs and the lenses are inserted. Contact lenses can be worn for about 6 to 8 hours without discomfort. Slight haziness after this time can be remedied by removing the lenses for a few minutes. Contact lenses, invisible and comfortable. A new look that's here to stay.
I think that's pretty amazing. When I first saw that, that is from Australia, of course, from sometime probably in the 40s. You notice that in that illustration, there were fenestrations in the lens. You saw 2 big holes, and he admitted that the lens can be worn for, 4 to 6 hours for haziness. And of course, I'm sure they get a lot of edema. So it's not so new after all, but certainly we've refined it. And so impression molding now in 2020, we pretty much do reserve this for a very irregular asymmetric eye. In our current technology, you get 10 million data points from these moles, and they're condensed down to about 250,000, 300,000 data points for grinding. These lenses fit are very precisely. They're great for large irregularities like blebs and tube shunts, very large pterygia. Unlike the seaweed-based materials that you saw in the video, now we have ophthalmic grade polyvinyl siloxane, which is what they use, to make molds for teeth as well. But this is an ophthalmic grade, very, very pure. These lenses, of course, are fully customizable. They can be multifocals, decenter the optic zone, and put up to 4 prism diopters of prism in any direction. So it's quite sophisticated these days. And so when you have really challenging what we call plateau graphs, like you see here, it's a very old graph that's elevated, what we call a proud graft. Same different patient, but same type presentation. Yeah, these are very difficult to fit with even conventional standard scleral lenses. So the molds really help us in that regard. And you can see from this picture that it can be highly irregular because it's molded directly to all the irregularities that we find in the eye. So yeah, it's really great. Takes a few minutes. This is a lady that liked scleral lenses. She was post radiokeratotomy, about a +8 hyperope, of course, after RK. She had worn some scleral lenses, but they weren't comfortable for her. So she saw the benefit, but wanted something that was more usable. So we leave it in about 3 minutes and we take it out. And it's very comfortable for the patient. We don't use anesthetics at all. And there you go. We have a nice mold. So you can see from this how irregular this cornea and this sclera is. Very much an oval shape cornea, a very irregular limbus. So an eye like this is very difficult to fit in one of our standard lab lenses. So eye print really has a thing. So you do get the true shape, the real shape, when you do an impression mold. Now let's move on maybe to some examination tips when you're examining your patients and you're looking for that optimum fit. So we'll spend a minute talking about technique. You want to dim your room lights, including your computer monitor if you have one there, because you get a lot of reflections in that. You angle the optic beam, the optic section, about 40 degrees to the side. If you're evaluating the clearance with fluorescein, as you see in this picture, you use white light, even though it is fluorescein. You can see that this particular person, if you look, had some radiokeratotomy scars there. Use white light, as I said, and you don't want to use too much magnification because it's very hard to focus. So I find on my instruments about 10 to 16 times is appropriate. And so what you see here, of course, going from right to left, is the corneas, the gray band, the post-lens tear layer, the PLTL, or some people now call it the fluid reservoir, is green, because stained with fluorescein. The black band is the lens, and then you see the front surface as well. So these are the different layers that you're going to see. Now, you want to look at it from several angles, and so in this case, you center the light source over the cornea and switch your oculars to the other side and look at various angles, because you want to see not only the central clearance, but obviously you want to see how the lens clears in the mid-periphery and over the limbus. So here's my photo lamp. So in the first instance, my oculars are straight on and the light source is 40 degrees to the side. The alternative angle then is we just switch these two and you have the other view. So not hard to do. Swing it around. And if you do want to look at it in the entire lens, then you put on your cobalt blue filter, open up the aperture so you see the whole lens there, and you want to see a nice even tear film here, or post lens tear layer. And one of my cues for this is I want to be able to see some iris detail, as you see here in the picture. You can see the pupil, you can see the iris. If you have areas of touch, of course it's going to be dark, and if you cannot see the details, then you have too much fluorescein, too much clearance. And so this is about, it is important to use a Ratten filter. That gives us this nice green glow. It really does excite the molecules in the fluorescein and gives us a much clearer picture. There are many different types of Ratten filters, and the ones that we use clinically are the number 12. So what you want to do is you want to compare that post-lens tear layer or fluid reservoir to the known thickness of your contact. Whenever you put a lens on, you should know the center thickness of your diagnostic lens. In most cases, you want to look for a 1-to-1 ratio. And what I mean by that is larger lenses tend to have more clearance and larger lenses tend to be thicker. And the opposite's true for smaller lenses. So when you first put it in, you want to look for a 1-to-1 ratio of the post-lens tear layer to the lens thickness itself, and that gives you a good monitor, a good metric. Dr. Stephen Vincent down in Brisbane, Australia, a very noted and published researcher, has done many studies, and he found that the central corneal clearance would decrease about an average of 76 microns over 8 hours. The rule of thumb that we've used for years is 100. So Dr. Vincent found a little less than that. But the important take home for this presentation is that 50% of that reduction takes place within the first 45 minutes of wear and 75% within 2 hours. So this has two benefits clinically. The first benefit is when we're doing diagnostic fitting, you want to put the lens on, evaluate it, make sure it's not touching, and make sure it's not excessively clearing like 500 or 600 microns. But then you want to let them sit. I have the patients go talk to the staff, go over their wear schedule and their solutions, have them schedule their next appointment, and then I see them back in 30 to 45 minutes to see how much settling has occurred. And then the second point is for your follow-up examinations when they're coming in for their progress checks, you want them to be sure that they're wearing the lens. I say at least 4 hours. So you don't want to see these patients first thing in the morning because you haven't had time to settle. So that way you have a true estimation, a true understanding of how much clearance is really there. Now, I speak a lot to people just getting into this and wanting to get started in scleral lens fitting, as I did only about 7 years ago. And the topic of OCTs come up is that, do I have to have an OCT, to fit scleral lenses? And the answer is, yeah, you don't, but they're very helpful. My good friend Ken Pullum from the UK, from Moorfields in London, has been doing this for many years. He's a well-known scleral lens mentor and icon. He calls it overly complicated technology because he's been doing it so long. He can just look at a lens and tell. Many different products out there. I don't know what's available in your market, but I'm sure there's something. This was an early OCT by Zeiss called the Visante, and it's not available. It's not made anymore. However, you can pick them up used sometimes. And the nice thing about the Visante is it really gives you a global view of limbus, bilimbus. We're denied by this. We can't get it in the United States anymore unless you pick up something used. But it's a great tool. Dr. Boschnick, my friend in Miami, took that picture. This is my image. We have a Zeiss Cirrus, which is not quite the same. You can see this particular patient had intacs. If you look in the colored regions, you can see the little hexagonal, especially on the right side. So this is the kind of view I get. And to get that view, we have to put auxiliary lenses over the optical area. So we have that. So it's not quite the Visante. However, it has other features for looking at the retina, which the Visante doesn't have. So we use OCTs to answer the question, do I have to have an OCT to fit scleral lenses? The answer is no. But I do tell people that I think in any modern optometric practice, there's so many uses for OCTs. It certainly has a place, in glaucoma monitoring, macular issues, diabetic retinopathy. So OCTs are very valuable pieces of equipment in your office. And if you don't have one, I would encourage you to look into it. So this is the view I would get with my Cirrus. And obviously you can see the lens, the clearance on the cornea there. The other advantage that we have with OCTs is that there's little drawing tools on them, so we can really see, you know, what all these values are and for monitoring the eye. So I like it, I really do. And it can verify what you're seeing in the slit lamp. When you look at the left, you might not pay attention to that little bump that you see there. But if it really does show up on the OCT, and you can measure that. And so it's a confirmatory tool. It's useful and nice. This is a Boston sight lens, and you have to turn it to, you know, the different areas, but you can look at all the landing zone, the limbal zone, and the you know, all the landings. So it's a nice tool to have. Really brings out what's going on. When you do this, at least for our product, they have what they call a horizontal raster, and so these are 5 slices that the image takes, and you can see you can click through those. And the point of these slides is when you have a raster system and you're looking for central clearance, as in a cone, a high cone or a proud graft, you want to orient the lines not only horizontally but vertically, because as most of us know, there's the central nipple cone is not as common as a low global cone. So oftentimes it's not the highest point of the eye is not right in the center, it's down below. And so if you orient the rasters vertically as well, you'll make sure that you're clearing, you know, the highest point on the cornea. Of course, so this is how we get the edge profiles. The person does have to change their gaze, which is not ideal in terms of centration, but at least it gives us some idea of how that lens is landing. So here's an illustration of the vertical raster, and you can see that there's 5 lines there. This is from a good friend, Dottie Fidel. Dottie's in Rome, and Dottie is just brilliant. She publishes a lot. She designs her own lenses. She just released a book. If you look on the Facebook page, ODs on Facebook or on our Scleral Lens Practitioners page, she announced the release of her book. She uses an OCT to design the lenses, which is really useful. This is an OCT from Italy. It's a CSO. It's made in Florence. We do not have this in the United States. This is, if you look at this is a ortho K Scleral lens, which I think is pretty amazing. You can see centrally it is, you know, in contact with the cornea. Dottie's amazing, and these are amazing pictures. I would love to have this OCT. Again, it's called a CSO, and it's available from Florence, Italy. The other thing that we do have, though, going on to another instrument, is tomography, and we get this with our pentacam. So tomography is defined as a method of producing a 3-dimensional image of an internal structure, a solid structure. And the important difference between tomography and tonometry is that it is, or topography, is it's not dependent on the reflection of the tear film, okay? So you get true elevation data in global pachymetry, okay? So we really like Scheimpflug for managing keratoconus because we can see the front and back surface of the cornea. So most of us will remember in our training about shiner discs, which is just a reflection of marble, 17th century, so a long time ago. And then we're all familiar with the Placido disc. That's the common topographers that we see in keratometers, where you have the series of rings. And that was an advancement over the shiner disc. And you know, it's common now. That's what most of us used. And you have this concentric array of rings, you know, reflecting the anterior surface of the cornea. Oops, I don't know what happened to that. Uh-oh, sorry about that, hang on. Let's get to where we were. Sorry about that. Okay, now we're back. So Placido disc, and here's a illustration of one. The problem with it is that you have unstable tear films, particularly in extreme dry eyes or very ectatic corneas. You know, they're distorted, obviously, and you don't get global pachymetry because you're not assessing the depth of the eye at all. You're reflecting off the surface. Whereas a Scheimpflug is a camera system. Okay, so when you have something that's non-planar, which means, you know, not an even surface, you can get, you know, false results from topography, whereas with tomography, where you're doing a slice through, as you see here, it's much more accurate. So Scheimpflug, KSSO, that's Spanish for, you know, what is this? I'm in Texas, so we speak a lot of Spanish. So with Scheimpflug, you get topography, as you see in the upper left. You get pachymetry, as you see in the lower left, corneal thickness, and then you get elevation maps of the front and back surface. And I want to emphasize that looking at the back surface of a keratoconic eye, or someone who has Fuchs dystrophy or any kind of posterior dystrophy, is very important, because in keratoconus, that's where the change occurs first. So who is Scheimpflug? I just thought this was it's an interesting name, that he was an Austrian captain who was a photographer, and his job, this is right before World War I, interestingly enough. His job was to fly around in a plane and take pictures of the Allied trenches and battle lines, you know, in France and Belgium. As the World War I was getting ready to start. And, you know, he noticed that as he's up in the plane and as the ground falls away, he would get distorted images. So, you know, how could he fix that? So this happens when your subject is not parallel to the plane of the film, you know, in the camera. Excuse me. And so what he did was developed an image system where all these lines intersected in what they call the Scheimpflug intersection. So he corrected the lack of the lack of intersection of these two images of the subject and the film plane. He brought them back to a common point and was able to make them sharp. And so that gives us pictures like this, where you see very, very distorted corneas, very advanced, obviously not in the same plane. And if you look up, if you look straight up, where you see the 21-25, 22-25, these are the different slices. There's 25 of them. The camera rotates. If you look at the upper left, you see the blue bar indicates the slice. And if you look carefully, you can see a little red image of the camera, and that tells you, you know, what angle that slice is. And so you can spin around and see all aspects. So it's really, really great. Another aspect that we find on the Pentacam is what they call the Belin Ambrósio display. And what that does, it's a very interesting thing. When we take elevations, that most of us know, who are familiar with elevation maps, that an elevation map is a comparison of the eye in question to the radius of a best fit sphere. Okay, so that elevation map is smooth. It's because it takes the average of the highest and lowest points on the cornea. And that's fine when we have a normal cornea, but when we have a very ectatic cornea, as in a proud graft, as in post-RK, and certainly in keratoconus, you know, the difference in elevation is quite large, and so you don't want that smoothing. So the Belin Ambrósio takes that ectatic area out. And it also, so you're compared to the normal areas, not the ectatic areas. And 6 separate indices are computed, and you get a global algorithm. And with that global algorithm, there's a certain value that above that value, and we'll look at that in a minute, you know it's ectatic. Below that value, you're normal. So here's Michael Belin from Arizona in the United States. Your standard best fit sphere, you know, averages all the different curves on the eye, and you can see how that would distort it. So the Belin Ambrósio then will exclude the most ectatic region. You can see in the bottom right there, the little red area, that's excluded. And so your best fit sphere is compared to the normal areas of the eye. And so the cone pops out because it's not smoothed. And so this is the whole display. The images on the upper left are the elevation maps for the front and rear. And then down below, the bottom two discs, which are more green, are the ectatic areas. So that's the excluded area, and you can see how much more elevated they are, how abnormal they are compared to the anterior surface. So this is, even though this is a very severe keratoconus, you can see that the difference in elevation, the ectasia, is much more pronounced on the back than it is the front. Okay, and you have these indices, and this is what I was talking about, the D value. And this obviously, if you look at the corneal thickness on the upper right, the pachymetry, you can see that this is a very distorted cornea. So his D value is over 27. 3 is the threshold, so obviously very, very ectatic. And that was the picture we saw earlier. Okay, so for many years, we talked about keratoconus and we talked about pellucid. And personally, I had patients that I said, oh, pellucid. And that was based on, we always want to know, what is it? Because it kind of, depends on how we're going to approach the fitting. So it's important to know. And most of us were taught, I know I was, that when you looked at a topography, if you had the so-called kissing doves or lobster claw, this was indicative of pellucid as opposed to keratoconus. And you can see here in this, these are K readings. These are power readings. Remember that topography, axial maps or tangential maps are power differences. They're not indicative of thinning. They're not pachymetry. So kissing doves is not the definition. Or lobster claw or crab claw, whatever you want to call it. That is not what pellucid marginal degeneration is, okay? And this is, again, from Michael Belin. Curvature is reference-based, okay? You can get asymmetric curvatures with a normal cornea when you're the corneal apex, the line of sight, which is always different from the corneal apex. That's what we call our angle kappa. And then your measurement axis don't line up. So these are normal variations. They're not necessarily indicative of pathology. So Belin says that PMD, pellucid, is one of the most misdiagnosed conditions when you're looking at Placido-based imagery. Placido-based imagery cannot get out far enough to the area of pathology and doesn't give you a pachymetry reading. So it's a very high false positive rate. In fact, I didn't put this in there, but Dr. Christine Sant, who brought us the modern eye print lens, the molding that we saw earlier, she and I wrote a paper August 2019 in Contact Lens Spectrum on the difference between pellucid and keratoconus. And so again, this is in all the keratoconus patients I have in my practice, which are quite a few now, I only have 2 that actually have pellucid, and this is one of them. So you can see here, this is a pachymetry map, and you can see the intense thinning down below in that band. So this is what pellucid looks like. And so this is the early image we looked at. You can see that he definitely doesn't have the thinnest area on the periphery as the axial map would show you. He actually has a normal periphery there. So don't be misled. So you guys like chess? You got to watch out for that queen. She can move in any direction. All right, so newsflash. Guess what? Cornea is not symmetrical. Anybody that's fit scleral lenses for any time has figured that out. In fact, it's highly symmetrical. This was a very, very good paper published by a number of friends of mine in November 2017, so almost 3 years ago. And they took 140 patients and mapped their sclera, okay? All right, very, very interesting. This is what they found, 140 patients. they found that only a little less than 6% had a regular spherical sclera. Only 28% had toric regular, meaning that's what we think of as with the rule or against the rule, that is steeper vertically or steeper horizontally. A full 2/3, 66%, had either high or asymmetric high or low points, or a periodicity different than 180. So what that means is that maybe the vertical meridian is steeper, but the amount of steepness superiorly versus inferiorly is quite different. That's asymmetric high and low points. Periodicity means that maybe the two highest points or the two lowest points are adjacent. They're not 180 degrees. They're not vertical, horizontal. You may have, 2 points together, nasally superiorly or temporally inferiorly, that are your asymmetric, and that's 66%. So no wonder, scleral lenses decenter and move about. And this is primarily because of what we remember as the spiral of Talot, which is the fact that the extraocular muscles, the extraocular muscles, the EOMs, insert at different distances from the limbus. And not only do they insert in different distances, but there's different angles associated with that. So these instruments, here's a couple. The study that I referenced was done on the superior instrument there. That's an SMAP 3D. And then the bottom one is from the Netherlands. It's Eaglet. And these use fluorophotometry, where you put fluorescein in and take a picture. This is from the SMAP, our good friend, Dr. Greg Denier from Ohio, helped develop this along with Dr. Don Sanders. So in the picture on the left, the red is the cornea, and they're not measuring the cornea. They are mapping the sclera, the elevation. Remember that in elevation maps, unlike axial maps, blue is below the best fit sphere, and therefore that's steeper. So blue is not flatter as it is, or less curvature as it is in an axial map. Blue is actually the steeper area. So this is an example of what we call with the rule scleral toricity, in that it's steeper vertically and flatter horizontally. However, you can see the asymmetry in the amount of steepness between the superior and inferior there, about 200 microns difference. And that may make a difference in how your lens fits. This is from the Eaglet, the competitor to it. You can see much the same type of image there. And then this is the Pentacam. This is the image we were talking about, Scheimpflug, and this is using their Scheimpflug camera. You can see on the left all the different slices that they took, but this is of the sclera, all right? And so you have the color map in kind of the central lower part, which shows the different regions. And then on the bottom right, you have your elevation map, similar to what we've been looking at with the previous products. And then superiorly, you'll have some angles, the scleral angles, and elevation keys. So yeah, competitive products, all trying to do the same thing in a different manner. Not cheap, but certainly worthwhile if you fit a lot of scleral lenses. So most of them have a database. So you take the information, you select the design that you're interested in, the product that you're interested in, and then those profilometers will say, okay, in that particular lens, we recommend this diameter, this sagittal depth, and this landing curve. Here's an example. This is from Eaglet, where here's the results, here's some differences, and you can see on the left-hand column there's a series of lenses that you could select from, and then that would give you that information for that lens. And so I think the ultimate goal of all this is empirical fitting, where we don't actually put diagnostic lenses on. And I just did a seminar last week with Dottie Fidel, Melissa Barnett, and Christine Sent. It's available on the International Congress of Scleral Contact Lens website, icscmeeting.com, if you want to watch that. And we talked about how this whole COVID pandemic really is going to accentuate empirical fitting, because patients are going to be uncomfortable, with putting lenses in that have been used in other people's eyes that have been disinfected, but the less we interact with the patient, I think the more comfortable they're going to be. So the ultimate goal is to take these measurements and then upload the data directly to the lab for the manufacture of that lens. So the lenses are going to fit correctly from the first. You're not going to have to put diagnostic lens on 1 or 2 or even 3 to try to see, well, what is the best fit. When you order an empirical lens, you come up with the prescription usually from their spectacle prescription as well as their keratometry measurements. That's how we do corneal RGPs. If you really want to put a diagnostic lens on, it's very efficient, I think, to take a corneal lens, a small corneal lens, just to anesthetize the eye, pop that lens on, as long as it stays in the eye, over refract it, and then all you need is the base curve, the power of that diagnostic lens, and your over refraction. Okay. So the idea is to get rid of these. We do a lot of testing in our office, and so I don't recommend that everybody have all this. A lot of these are just test sets that we don't actively use, but they do pile up. And now the American Academy of Optometry has, and American Academy of Ophthalmology has published very stringent guidelines for disinfecting lenses, which actually are quite onerous. So patients want to know, well, that's great. How do I get this thing in my eye? Brian Thompson in the UK sent me this, which I think is kind of cute. It may look that big to our patients. There are devices that are available to help people. Craig Hirschoff in Miami, Florida has one such device. This is a little telescoping stand by Dr. Majoub in Colorado. The stand itself will telescope, so a patient may be more comfortable standing than sitting. It does have a light source in it. You can see that the lens is lit. There's a little internal light in there. It telescopes up and down, so that's quite unique. This is made by Dulce, which is the same type idea. There's a kind of a landing light that helps the patient. So if a patient is only has one arm or one hand, or rheumatoid arthritis, or maybe injuries to their fingers, or they just have a hard time opening their eye, stands are really nice. We call this truck stop inserter. United States, we have truck stops because it's such a big country and trucks go all over. This is just a coffee cup that you cut a hole in the bottom of the coffee cup and stick your plunger in. It works. It works just fine. A patient of mine came in. He said he lost his inserters, and so these are what we call wire nuts. If you have 2 wires that you want to tie together, electrical wire, and you want to insulate those wires, these are insulated plastic caps, but they make pretty good holders too. So I was pretty amused with that. It's important that the patients have their tools, and so we always give them a set when they get their lenses, but they can be lost or left in a car, purse, or just misplaced. So in our office, we offer a multi-pack. We give them a big discount. Say, here's 5 sets of the things. Put them everywhere so you don't lose them. I'm going to change gears here for just a second, if you'll permit me, because this is about new technology. And I want to share something that I saw at a meeting a year ago from George Waring, a surgeon I think he's in South Carolina. Very, very kind to share this with me and with us all today, that we can adjust the intraocular lenses in vivo in the eye through a technique called refractive index shape. So after this particular lens is inserted, then and measurements are taken, and the refractive index and the power of the lens is put into the lens while it's in the eye, and it's measured. It's called phase wrapping. And what's amazing for this to me is it's not etched in the lens. This is reversible. This is what it looks like on the eye with the patient, how that phase wrapping is done. And so on the left, you can see basically a blank lens, right? And on the right, you can see that power has been, applied to this. So the spherical aberration, which is how they change the power, is changed many, many times. You can see from 0.0019 to minus 0.16. So this is how the power is created. And what's fascinating about this is they can change it. It can be a monofocal for distance, perhaps monovision with two different powers in the eye, or they can make it a multifocal. And if the patient doesn't like the multifocal, they can change it back. So I find this extremely fascinating, and maybe this will be applied in the future to a contact lens. So these are all the capabilities of it. It creates extended depth of focus and can create a multifocal lens out of a single vision and then turn it back again. So it's pretty neat stuff. I wanted to share that with everybody. So I had a great time speaking today. I hope you found this informative. This is my contact information. Follow me on Instagram. We have a Facebook page called Scleral Lens Practitioners. We ask you to answer a couple of challenge questions to be admitted. But we have over 6,000 members, and we're fortunate to have some of the best, most knowledgeable people in the world participate on that page. So I invite you all to look it up on Facebook and join it. Follow me on Instagram. So that's it for me. I'm happy to answer some questions, and I hope you found that useful.
Hello, thank you, sir.
Thank you.
Thank you, Dr. Thomas P. Arnold, sir, for this informative session. Also, thanks to all the attendees for the participation and patience. Now we are to begin with our discussion session. So if you have any queries, then you can just write down there in the chat box. Sir, should I read out the questions for you?
Yes, please.
Okay, sir, there is one question. What was the relation of lobster claw in relation to PMD? If you can explain once again.
Sure. The appearance of a lobster claw is an appearance on a axial map, okay, on an axial map, and it shows it's an artifact, okay. It looks like this lobster claw or kissing doves, whatever you want to call it, and people interpret that as increased thinning on the inferior cornea when it's not, okay. The definition of PMD or pellucid marginal degeneration is a band of thinning 1 to 2 millimeters from the limbus inferiorly, where the thickest part of the cornea lies above the band of thinning. Unlike if you think of a central cone, the thinnest point of the cone and a central cone is in the middle. But in pellucid, the thinnest point is below the apex. And so you don't know that unless you do pachymetry. So looking at a topographical map, an axial map or a tangential map shows power change. It doesn't show thinning. So that's been misinterpreted. Hope that helps.
Sir, then next, can you share the practice protocol or the way you practice?
Well, that's a big subject. Can we be more specific? My practice, what my practice is?
Okay, I'll move on to next. For the beginners, what could be the possible resources to broaden the knowledge on scleral contact lens?
Oh, there's a lot of them. There's a lot of them. A number of very good ones. Um, and what I'll do is I can email this to you. I'll tell you, but I can email you, and then maybe you can send it out to the members. Uh, the a very good book, which is free to download, is called A Guide to Scleral Lens Fitting. A Guide to Scleral Lens Fitting. It is by Afe van der Warp, and it's free for download. So just look up A Guide to Scleral Lens Fitting, and you can download that for free. It's excellent. The other thing you can get also for free is scleralsuccess.com. All one word, scleralsuccess.com. That's a free book for download written by Dottie Fidel and Melissa Barnett, and it's excellent. So those are two books you can get for reference that are at no charge. I watched a lot of videos when I started, and the best sources for videos, one is the Scleral Lens Education Society, and that website is sclerallens.org. So sclerallens.org. And you have to join it. You have to become a member, but it's free. They just want you to register and give them an email. And if you look under their learning or their doctor resources, there are many webinars there recorded, and they're great. Greatest fitters in the world. So sclerallens.org. Become a member and look at their webinars. And then another excellent source is the Gas Permeable Lens Institute, and their website is gpli.info. gpli.info. And has a lot of resources. So again, look at specialty lenses and look at resources. Those are all really good. Join our Facebook page, Scleral Lens Practitioners. And then, of course, there's congresses all over the world, which probably are now, delayed because of the pandemic. But you have to read, you have to study. Yep. I will email you those that list. Okay, and that way you can maybe pass it out to your colleagues.
Okay, sir. I'll move on to the next question. What are the main parameters do you think for fitting patterns?
Say that again?
What are the main parameters do you think for fitting patterns?
The main parameter, one of the main, is horizontal visible iris diameter, right? And you want to measure the horizontal visible iris diameter, because the bigger that is, the more elevated that cornea is going to be. The lens that you select, you want to be about 1.5 to 2 millimeters beyond that, okay, on either side. So let's say if you had a 12 millimeter cornea and 2 on a side, you would want a minimum 16 millimeter lens, diagnostic lens. The other thing to do is look at your patient from the side, from 90 degrees away. Have the patient look straight ahead, and you get 90 degrees to the side where you're looking, on the temple side, and either you pull the lids out of the way or have them do it, and just look at the cornea. If you do this regularly enough times, you'll start to recognize flatter corneas, normal corneas, steeper corneas, and that can gauge, even without any tools at all, that can give you a starting point for your diagnostic lens. And then the other thing I would say to all the colleagues is, you know, pick one or two fit sets, pick one or two lenses and concentrate on those lenses. Learn those lenses really well, because over time, then you'll learn which lens in that diagnostic set are the ones you use mostly. I think if you try to collect 4, 5, 6, you know, different fit sets, trying to get the ideal set, you won't be familiar with any of them, and you'll just confuse yourself. Anything else? This picture that you see there is good friend Nick Rumney from the UK, very, very brilliant chap. He used to be president of the British Contact Lens Association. We spoke in South Africa and we went on a little safari. So that's our good friend Nick. Any other questions?
Sir, I guess we have some technical issues. So further questions
Oh,
will
okay,
be there
yeah,
for you.
okay. Kapil, I'll send you those
Uh,
links, okay, that I mentioned.
okay, sure, sir. The tear reservoir role in scleral contact lens fittings, and what are the indication?
Can you speak up a little bit? You're not as loud. Say that again.
Okay, sir. The tear reservoir role in scleral contact lens fitting, and what are the indication?
What are the indications for scleral fitting?
Yes, sir. Yes,
Uh,
sir. What are the yes, tear reservoir, sir?
well, you know, mostly it's keratoconus, which is much more common than we thought. Uh, Internationally, we may see 1 in 375 people, 1 in 500 people may have keratoconus. That's the most common. In the United States, we have a lot of people that underwent radiokeratotomy, where they made cuts in the cornea, you know, in the 70s and 80s. And these eyes are very, very irregular now and mostly farsighted, very hard to fit in a conventional lens. Then we have dry eyes. In the last year or so, a couple of years, several manufacturers, labs have received approval to use in severe dry eye, Sjogren's syndrome, rheumatoid arthritis, graft versus host disease. Those are the most common. A little less common are, you know, athletes who, you know, need the lens to stay in, and, you know, under sports activities. Mostly it's keratoconus and post RK, post LASIK ectasia. Yeah.
Uh, okay, sir. Sir, there is another question from the Hirana Tal, sir. He is asking for what would you determine the successful scale lens fitting, and what are the factors you consider?
What's the success rate?
Yes, sir. How would you determine the successful rate in scale lens fitting, and what are the factors you consider?
Well, I think our success rate's well over 90%. They're very comfortable lenses, and in many ways they're very forgiving. You have to be careful with your patients that you're not causing any long-term harm to the cornea. Like if they have a graft, you want to make sure that they're getting enough oxygen so the endothelium doesn't fail. You want to make sure you're not abrading the cornea. You want to make sure you have clearance. And then you want to make sure that the lens doesn't settle too much over time and dig into the conjunctiva. But if those are all pretty easy to monitor and remedy. So I'd say our success is well over 90%. Lots of times people that will not choose not to continue scleral lenses is because of maybe handling issues, or it's just too much trouble for them to clean them and fill them with saline and so forth. Um, you know, what do what other factors? For some people, it's cost. At least in the United States, I mean, they're fairly expensive. Some people have medical care, vision care, which has coverage for it, and they can afford it. Probably about 20% of our patients are self-pay, and we charge more for this. So cost may be a burden, whereas in other countries that have a universal health plan, which has them covered, like the UK, cost is not an issue. So I think cost, and then just the ability to handle and take care of the lens are the factors in fitting these lenses. They're comfortable, and in most cases you see very, very well.
Okay, thank you, sir. Sorry for the inconvenience in between. There's a next question. Is there any relation to glaucoma and scleral lens in your view?
That's a great question, a very good question. That is very controversial. There are a number, and there's a lot of there are many papers on this. Some people feel there is an association, other people feel there is not. I can tell you that when you read the data, some people find associations, some people don't. So the answer is the real answer is we really don't know. But I think all of us feel like it's imperative to watch it. People that have glaucoma, you have to watch it carefully and monitor their glaucoma. This is especially true if you're fitting, someone has a filtering bleb or a tube shunt, or has just one eye. I have a patient like that. I have a patient that's actually only has one eye. He has a prosthesis. And then in the quote good eye, he has a shunt and a bleb, and so very high risk individual. So the jury's out, but I think we're all cognizant of it. The controversy is that how do you measure it? There are instruments that are put on the sclera, or they're through the lid, but again, how are they calibrated? There's no good database on calibrating for that different material. The lenses, the tonometers we use, whether that's a rebound like an eye care or applanation tonometry or non-contact tonometry, those are all based on the architecture of the cornea. They're not based on the architecture of the sclera or the lids. So there's and then the other argument by anatomists, of which I know several quite well, is that the outflow, there's at least 4 different mechanisms for outflow of the fluid from the anterior chamber. So if one becomes compromised, the others would take up the slack, and that Slim's canal may be too deep to be impacted by a scleral lens. So these are all unknowns. And one of the fun things about scleral lenses, and those of you who are younger and have years of practice ahead of you, it's just such a great time, because with scleral lenses there are many controversies from people that are very experienced, very, very smart, and they have completely different views of how big the lens should be, how much clearance there should be, how much oxygen do you need. So it's an interesting time. So anybody that's going to be practicing for the next 20 or 30 years, there's a lot of new information to come out, and it's a very exciting time.
Thank you, sir. We have almost answered all the queries. If anybody have any queries, then you can just unmute yourself and directly ask here. We'll just wait for a minute and then we'll continue.
There is a problem while wearing mini scleral. The fogging is there. How we can get rid of these fogging?
Yeah,
with the lenses.
That's a great question. Well, that's a good That's a good career goal for you. And if you fix that, then we'll all be happy. No, it's a common problem. It's a very, very common problem. I can tell you some of the remedies, some of the causes, and some of the remedies. But I will point you to a paper in the Contact Lens and Anterior Eye, which is the journal published by the British Contact Lens Association. Look in the March issue. There's a very good article by Muriel Shornack and some other noted researchers on fogging, on scleral lens fogging. And they go through all the causes and all the possible remedies. And the conclusion of that article is we really don't know. There's not one cause, there's not one answer. It is a conundrum, and it probably, midday fogging is probably the most challenging thing that we face in our fitting, maybe that and decentration. So it's a very good question. The common things to avoid are not having too much clearance, excessive clearance. And by that, I mean, again, the clearance is going to be different depending on the overall diameter of the lens. But in general, studies show that if you keep the clearance between 150, 125 microns and 250, you'll have less fogging. That's one kind of rule of thumb. The other rule of thumb is that you don't want excessive limbal clearance. You don't want to land on the limbus, but you don't want an excessive clearance. And I would define that as anything more than 100 microns, because then you may get a suction effect and you draw things in through the limbus. The third thing, of course, and probably the most common, is that you want to align the haptic. It's very, very important that you have pretty much a uniform landing of your lens, in the haptic or the landing zone. And you don't want it too tight. If you completely seal the lens off, then you'll get stagnation, and that'll lead to fogging. If it's too flat, particularly in any one area, then you're going to get excessive tear flow in, and that's going to bring in, mucus and stuff. And a number of practitioners, including myself, feel that if you're not aligned properly, the lens can be rocking, especially with the blink, and that irritates the goblet cells to produce more mucus, and then that rocking pumps stuff in. So I would say to you, just some easy rule of thumbs is not too much clearance centrally, not too much clearance in the limbus, and do the best job you can to align the lens as it lands without sealing it off. And a good tip for that is if you have lissamine green vital dye, take it and dab it on the bulbar conjunctiva. Do it temporally, and not an excessive amount, just a good amount, not excessive, and then have them blink just a couple of times and look at that under white light. And if you have any really obvious areas of lift, that lissamine green just pops right in there and you'll see it. And in that area, that's where you want to try to flatten it a little bit. But it's a very good question. It's very frustrating.
Thank you so much, sir. Now, I guess we have answered the most of the questions. And considering the time limits here, I announce the closure of the discussion session. Before ending today's session, I'd again like to express my sincere gratitude towards the presenter, Dr. Thomas P. Arnold, sir, and all the attendees. Also, I'd like to appreciate all the helping hands for the iTalks program. Herewith, I am ending today's session requesting all of you to drop your reviews and feedback. And sir, we would love to get the feedback from you too.
Great. It was my pleasure, and I hope everybody enjoyed themselves, and good luck in your fitting. It's a great discipline. I'm so glad to be an optometrist, and I've been to India twice, and I certainly look forward to visiting you all in Nepal someday soon.
Thank you so much, sir, once again. Thank you, everyone. Stay safe and keep in touch. Thank you.
Okay, sir. Here we ending the session. So we will be keep in touch with the WhatsApp, and I'll make you call in WhatsApp, sir.
Okay, great. Bye-bye.
Bye, sir. Thank you so much, sir.
My pleasure.